Okay, so I think we'll make a start. My name's Simon Prangnell. I'm the clinical director for psychological medicine in Oxford, but I'm also a neuropsychologist, and I had the great privilege of working with Catherine as a colleague in the department here in Oxford. And it's fantastic to be able to welcome you all this afternoon to the first in the series of these Division of Neuropsychology seminars. Catherine will say a little bit more about the scope and range of these seminars as we go along. But really, I think it's just to give you a flavour of what it's really like to work as a neuropsychologist clinically, to sort of go beyond what you can get from textbooks to get a real feel for what it's like to work with patients. So without further ado, I'm going to hand over to Catherine in a second. It's difficult to do interactive Q&A as we go along with these webinars. So what I'm going to ask is, if you do have questions, there will be time for questions. But if you can post them in the question and answer box on your screen, what I'll do is I'll keep an eye on the questions, and then at different points we'll pause, we'll cover the questions, and if there's anything that we don't get to cover within this session, we'll find a creative way of posting responses afterwards. If you have any technical issues, please can you use the chat for those. So reserve the chat for any tech problems, but please use the Q&A if you'd like to ask Catherine anything. So I'll hand over to Catherine. Thank you.
Thank you, Simon, and a big thank you also to Lane Whitaker joining us to do signing. So, as Simon said, this is just to give you a flavour of what it's like to work in neuropsychology. And really the impetus for it was that when I worked full-time clinically, one of the things I enjoyed most was being in clinic with an assistant psychologist or a trainee, and between cases or over a cup of coffee, just discussing what we were doing and why we were doing it. And I think colleagues found that quite useful. And what I tried to do was to impart some tips that I'd picked up over 30 years in clinical neuropsychology practice. And as Simon said, the sort of things that you pick up viscerally that you might not write in a textbook. And so that's what these sessions are about. First of all, a couple of disclaimers. So these are absolutely noddy sessions. So if you are already quite experienced as an assistant and perhaps you've done a couple of posts in a neuro rehab setting or something, you may walk away and say, oh, know all that. So maybe that's not a bad thing. It shows at least you can reassure yourself you've got the basics. But this is not teaching you to be a neuropsychologist. It's really basic. The second thing is that it's no replacement for supervision. If you're working in neuropsychology, you need to get yourself good supervision. And I mean, even right at the end of my working clinically, I would discuss cases with colleagues. I would buy in clinical supervision. And if a supervisor disagrees with something I'm saying here, we'll then go with what the supervisor says, because that's most important. If in the course of these 4 sessions I talk about any clinical cases, I will either have got written permission from the patient to use their case for teaching purposes, or it'll be an amalgam of a number of patients that I've encountered with all the personal details changed. But I may want to try and flesh out some of the things I'm talking to you about with believable, credible, and sometimes real examples. So to get into the meat of so this first session is about testing. It's about psychometric assessment. And I think one of the things to say is that poor old neuropsychology, I think, has got rather a bad press, because a lot of people think all we do is test bashing. And neuropsychology is far from that. And that's what I hope to illustrate over these 4.5 hours. Neuropsychology, to my mind, is an art as well as a science. It requires a lot of analytical, intellectual, problem-solving aspects, but it also requires an enormous amount of empathy and emotional intelligence. And it's what makes it such an exciting area of psychology for me, is having to put these two things together. So testing is anything but boring, and that's what I want to try and get across to you. So completely basics, and I said it would be basics. If you open a test manual, quite often what it starts off with is, you know, you need to have a well-lit, well-ventilated environment, blah, 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 etc. But, you know, why is that? And actually that's quite important. And you often see people trying to do neuropsychological testing. They're given some, you know, pretty grotty back room in a hospital and it doesn't have a proper window, etc. But when you're doing testing, you're doing controlled behavioural sampling. You're doing an experiment, if you like, each time. And so it's important that you control as many of the variables as possible, because you'll see when we come on to look at the test results, I mean, there's a lot of noise in the system. So get to know where you're working. You need to know what time the cleaner comes and hoovers down the corridor. You need to know, you know, what happens if you open the window? Do you get ambulances reversing, etc.? And you're going to be with that patient for quite a prolonged period of time. So you need the environment to be nice for you both. Many times you see people are working at desks, those old-fashioned desks where there's a board down the other side so the patient can't get their knees under the desk. It sounds like nothing, but actually making the experience pleasurable and you know, comfortable for the patient is important. So more on basics. You need to learn the test instructions. In the beginning, it can be quite difficult to manage your, you know, your clipboard, the test materials, the test manual, the relationship, the whole thing. And if you're struggling to, you know, remember the test instructions, it's perfectly reasonable to say to the patient, this is a test I haven't given very many times before, so please bear with me. I'm going to read the instructions so I can be sure to get them absolutely correct. I mean, that's perfectly fine. Because when you're testing, you're doing a lot of things, and that's why it's so interesting, because you're not only asking the questions in a standard, valid and reliable manner, you're also recording what the patient says, but you're also processing the whole situation. So you're looking to see, are they paying attention? Are they in pain? Are they making inappropriate jokey remarks? You know, what's happening? Because you're, as we'll come on next week when we talk about formulation to look at, you're developing hypotheses all the time and looking for disconfirming evidence. So you need to be processing this all at the same time. You need to find a way of noting down their responses without putting a great tick and a cross so they can see. You need to find a way of giving them some sort of feedback that is not giving them any answer, and that can be quite tricky. I tend to say, good, yes, whatever. You'll probably, some of you who are testing already may have experienced that particularly very able subjects find this irritating not to get the answer, and particularly to have to go on with some tests like the Wechsler until they're getting a series of incorrect responses, and that some bright people find that very irritating. So you're having to manage the relationship, and probably, I don't know, but probably a lot of you are younger women, certainly younger people, who may be testing people my age or older than me, and managing that whole dynamic without seeming arrogant, but being sympathetic to the fact it's quite stressful having your intelligence tested. And how stressful would that be if you thought that you were beginning to dement or beginning to go off? So I'll say a couple more things and then I'll pause to see if there are any key questions coming out. But the testing is also about putting the patient under pressure to a certain extent, but also bringing the best out of them. And it's also important not to cut any corners. Again, sounds completely basic, but I've encountered qualified psychologists who, for example, on the vocabulary test of the WACE, don't show the test card. If you're not showing the written word at the same time as asking the meaning of the word, you're altering the parameters of the test. Or I can think of assistant psychologists who have administered, for example, an initial letter fluency task. So that's where you give a patient a letter of the alphabet and you ask them to name as many words as they can think of beginning with that letter, but not people or places. And you start timing them. And what often happens is people go blah for about 25 seconds. And then they sort of grind to a halt. And I've seen assistants just stop recording at that time. That's not the test. The test is 60 seconds. And you quite often find people will come up with a few more things towards the end of the 60 seconds. And a final point is it's very important to write down virtually verbatim, or as much as you can, of the patient responses on all tests, not just memory tests, but intellectual tasks, and obviously language tasks. Now, why is that? Of course, you know, when you're doing a lot of testing and, for example, you might be doing a general knowledge test on the WACE, and you can see from the response the person's given that it's going to be a 2-point response. So isn't it easier just to put in a 2? But it's important because there's so much going on that you might not know at the time what it is you wanted to look at subsequently. It may be that the patient has some very subtle language changes and language difficulties. It might be, for example, that they were developing a form of frontotemporal dementia, a semantic dementia, which is where you get degradation of the knowledge of the world and world meanings. And they might lose a sense of, for example, if you asked a semantic dementia patient, do they like cheese? They might say to you, cheese, yes, is that yellow with holes? What is that? And that kind of deficit can be very hard to pick up. You might want to have recorded exactly what somebody said. It might also be the case that you want to look back later and see what they did and how they did in a previous assessment. And psychologists working with children and young people, I haven't done that myself, but I understand from them that it's particularly important because as a child ages, they go into a different normative age cohort. And therefore you might want, when you retest them, say they're starting secondary school or something, you might want to look and see, has their score dropped because they're saying the same thing, but they would be expected to say more because they're in a different age cohort? Or have they actually dropped skills? Are they losing skills? So there are all sorts of reasons why actually recording verbatim and keeping as much information on the sheet and things, noting points of time, how far you're through the test can be relevant. Simon, are there any key questions coming in that I need to try and respond to?
I've got one that's literally just popped up in the chat, which I'm reading now. Yeah, so very topical. So given the importance of an appropriate testing environment, what are your views, Catherine, on the feasibility of remote virtual neuropsychological assessments using a video link?
Well, that's a good question, but that's it's a very good question. I mean, that's probably beyond the scope of what I'm talking about, and I would direct you to some guidance that the Division of Neuropsychology has produced on this, on remote neuropsychological assessment, and there's also some wider BPS guidance on remote assessment more generally. But absolutely right, it is much more difficult to control the patient environment, isn't it? I think that it just shows how difficult it's going to be. And I think if this situation continues, we're obviously going to have to begin to develop, I would have thought, some sort of template or ground rules to support people. I mean, there's so much in that. I could speak for another half hour on that alone, Alice, but I think, of course, it depends on the age of the person that you're testing. I think sometimes kids are actually more comfortable with it. Older people find you can spend half your time just working out how the volume works before you even get round to testing. So, yeah, I think that's a good point. Anything more at the minute, Simon?
No, we don't have anything else.
Okay, I'll keep batting on because I've got lots to say. You might also support me in the chat line to say, you know, if this is helpful or if you want me more detail on something and that kind of thing. So the other thing I would say is that I think, you know, sometimes I hope I haven't in the past, but I think sometimes assistant psychologists who are used to support departments by being trained to do standard reliable testing, or particularly in research protocols, I wouldn't say they get abused, but potentially can. You can sometimes feel required to, you are required to test 2 or 3 patients a day, and that's, you know, that's a tall order. But you might also be asked to sit in when your supervisor is testing, and you might think, oh, you know, how boring is that? But I would really advocate you to take advantage of that, because each personality is different, but each cognitive profile is different. And also watching how your supervisor works, you can learn a lot. We'll come on next time to talk about the whole clinical interview and the overall formulation, but you'll see quite experienced psychologists will do things like perhaps go on beyond the failure criterion just to test what the patient can do. Or they might, I would, on occasions, for example, if I'm doing the block design task, I might, when I've administered the test, I might then put a Perspex clear sheet with squares on it over the template to see if that aids the patient. So you're trying to probe why is it they're failing? What is it about the test? And I would also say, even if you're required to do a lot of testing, or maybe you're required to test controls, don't think, ugh, you know, how boring is that? That's not somebody with a deficit. It's really about bums on seats, if I can use that rather crude expression. The more experience you get, the more you test, the more you begin to see how much noise there is in the system and what outliers you can get. And if I don't know if you've seen, but often neurology colleagues ask a patient to walk across the room, and they do that with every patient, not just ones who are under consideration for a degenerative movement disorder. And that's because by doing that, you get your eye into how people age, what a broad-based gait looks like, what ataxia looks like, and you just get your eye in. And that's in the same way, if you do repeated testing, you get a sense, and particularly, again, if you learn a battery, you get a sense of what are the problems with those tests. Again, it might be a little bit advanced for some of you who are assistants, but I think there are problems with a lot of our tests, and often the second form norms are a bit dodgy, or I don't know, there are tweaks and twiddles with a number of our tests, and you get to know them and be able to account for them and take them on board. I want to go on a bit to interpretation, because I think that's also very important. As I said, there's a lot of noise in the system, and you just have to think about, for example, if you think of the Stroop test, some of you will know this is a set shifting test where you have columns of words, they're the names of colours, but they're printed in different coloured ink. So you have red written in a blue ink. And the first time you're reading the full columns as quickly and as accurately as you can, you just read the words, red, blue, tan, green, etc. But the second time, on the second trial, you're required to name the colour of the ink in which the word is written. And so you have to, what we call in the jargon, you have to inhibit a prepotent response. Your automatic impulsive response is just to name the colour on autopilot. And if you try doing that with a headache or a hangover or whatever, you'll see, you know, just how much more difficult it is. I mean, I often think as well about an early paper I gave on epilepsy surgery, which had quite a lot of histology in the paper, and I didn't feel comfortable about really what I was talking about. And I was so anxious that at the end of the talk, I was paralyzed. I couldn't process the questions that people were asking me. So you have to think this is some of the noise that's in the system of the people that you're testing, and you have to sort of take that into account. You have to remember, of course, Bonferroni, and you know, for every measure you take, there will be some that are positive by chance. You have to beware of the test name. I know this again sounds absolutely ludicrously simple, but I've seen probably occupational therapists, I'm embarrassed to say, rather than psychologists, who, for example, administer a test of memory and the patient fails, and they say, well, the patient's got a memory problem. It could be, but it could be that the patient has, well, they could have an attentional problem or goodness knows what, but they could have a very subtle language problem, and particularly receptive deficits. So comprehension deficits in aphasia are often subtle and difficult to pick up. So, you know, expressive language, either the patient is aphasic floridly in speech or they can't speak, but it's difficult to pick up a receptive deficit because you're likely to say, you know, come and sit here and show them where, or would you like to put your cardigan on, or whatever. And those of you who've worked with aphasic patients, stroke patients, will know that they don't say, Catherine, I can't understand what you're saying. They latch on to key words that they think they've understood. And you have this sort of strange interaction where you feel you're not quite getting it. So if you're testing with that patient with a memory test, they're going to fail. Another problem I've encountered, again, sounds incredibly simplistic, but a bit of a clanger, is I've seen a psychology trainee assume that because a test score came out as average, that it was therefore unimpaired. And of course, that's not the case. Of course, you will know that in any adult test battery, you will usually, if culture permits and first language permits, give some measure of pre-morbid ability. So the National Adult Reading Test or the test of pre-morbid function, these are tests of non-phonetic words, and therefore the word is either in your lexicon and you know how to pronounce it or not, and a regression equation allows us to guesstimate pre-morbid verbal function. And if you think of the bell curve of the Gaussian distribution, the normal distribution of intelligence, if you, well, no, actually, let me, I'll come back to the point I was making before, but if you think about that curve, one of the things that's important is to be aware of how different tests are, the results are expressed as against that normal distribution. And so what I used to have in my test norms manual was I used to have the bell curve drawn out, and then I used to make sure that I had standard scores. So standard scores, for example, for the WAIS, the mean of 100 and the standard deviation of 15. And then for T-scores, standard deviation of 10 and mean of 50. You'd have the percentiles. You'd have Z-scores, so that you know that the Z-score represents a standard deviation. And so what you need when you're interpreting a cognitive test profile is to be able to switch between these different forms, these different expressions, if you like, of test results. Anyway, I'll come back to that in a minute. But so if you look at a bell curve, and you can see that if a person has a standard score that's 2 standard deviations above the mean, so they have an IQ of 130, and they drop 2 standard deviations, they'll still be in the average range, which means not that they're unimpaired, but that, you know, they're going to struggle day to day. Well, sorry, they're not going to struggle day to day. They're going to appreciate a deficit, but still be able to function. Whereas if you're of average ability and you drop 2 standard deviations, you're going to be, you know, you are going to be struggling. So again, where you start makes considerable difference. So again, to go back to that comparative, I think that's one of the things that's muddling when you try and interpret test data and you see, you've got all your results in front of you. You need to be able to get slick at switching from one to the other. So you need to know that a percentile of 16, the 16th percentile, so 84% of the population would do better than you on that test, is equivalent to a standard score of 85. That gives you a sort of lock-in. And these are important when you're trying to compare scores and look for deficits across a profile. And you need to watch out for some dodgy things like STEN scores. I think some of the, there's some Thames Valley frontal tests that are executive type tasks that have STEN scores. So they have scores from 1 to 10, and they have a mean of 5.5 and a standard deviation of around 2, which means that you're moving a lot of variance with only one integer, so they can be difficult to interpret. It's very, very difficult to give a sort of rule of thumb around what to do with test data, but you are looking for patterns. You're looking for the relationship between the current performance and pre-morbid performance, and you're really looking for something that you think is going to be less likely than just by chance. So an algorithm that a colleague and I worked out when we were looking at a lot of test data sets for a big randomized clinical trial where we didn't have the opportunity of being seeing the patients all the time was that for mild to moderate impairment, you're probably looking at 2 scores in a cognitive, so that's 2 measures that are 2 tests of a particular domain like memory that are more than 2 standard deviations from the expected level. And probably for moderate to severely impaired, you'd expect to have a couple of measures that are at least 2 standard deviations from the expected level in maybe 2 or 3 domains. That is suggesting to you something overall going on. And as I was saying earlier, if you test people who are, clinically unimpaired, asymptomatic, you may well get some funny anomalous results because of wavering attention, or I don't know, all manner of reasons, or they suddenly got distracted about what they were going to cook for dinner or whatever. I would never write a report the same day as I'd done the testing and the scoring. So the scoring, again, it sounds noddy, but always do your adding up several times, check it, check you've got the right line in the manual, do it again. We all make mistakes. And then I take a step back. And that's what I said in the subtitle I think I put online, which is, statistical versus clinical significance. And again, we'll talk more about that next week when we're talking about the overall picture and formulation. But, you can see there could be a couple of results that are not that are statistically impaired, but would you take a step back and say, well, if this is my grandmother, would actually I be worried that she's dementing? You might not. I can think of a cognitive test data set that a colleague showed me that he was looking at with a child, and I think the child, I can't remember, was 9 or 10 or something, and we were looking at the child's intellectual performance on the WISC, which is the children's version of the Wechsler adult intelligence, the children's intelligence scale, and there were some above average scores, and then some, it was really all over the place. There were some really below average as well as low average scores, and we thought, my God, what's going on with this poor child? And then my colleague actually sort of took a step back and had a rethink about it, and realized that what we were looking at was actually a child who went to a local, very famous prep school, and who was being brought up in an academic, intellectual family household. So certain faculties, his knowledge of word meanings, his general knowledge, his social cognition were sort of hot-housed, if you like. But actually, he was a child of quite modest intellectual ability. So in fact, it was all the other way around from what we were looking at. We'll talk more about interpretation and the overall formulation next time. And I'll stop again in a minute for some more questions. But I suppose what I'm saying overall is it's really interesting work, but you've got to do it intelligently. It's not like taking a photograph. It's it's as good as the effort you put in, and it really is worth putting the effort in. And again, when we talk about formulation next week, I'll talk a bit more about report writing. But in terms of the interpretation of the test data, of course, at the beginning, you're not going to be interpreting. At the beginning, what's going to be happening is that you're going to be looking at a load of numbers and thinking, oh my God. But what I'm encouraging you to do is to begin to look at patterns, to begin to try and see the relationship between the tests. And what will happen if you've got good supervision is that your supervisor will say what they think is going on. And then as you get more experienced, hopefully they'll encourage you to have a first stab at what you think is going on. And then, you gradually sort of gain more experience and more confidence. And ultimately, where you want to get to is to be able to give an opinion. So when neuropsychologists are writing reports, they're usually asked a question. Again, we'll talk about that a bit more next week. But I believe very strongly it's important to give an answer to the question. So you see a lot of, I think, not very good reports that say, oh, this person was a pip up on this and a pip down on that. It doesn't really tell you anything. I think your report should end with something that says something like, I don't know, depends what the question would be, but formal neuropsychological assessment of this 68-year-old right-handed retired engineer with a 6-month history of subjective report of memory difficulties reveals, and then you say what it shows. And then in the second paragraph, you kind of answer the question, and it might be there are definite signs of deterioration in cognitive function or a selective memory deficit or something. Or you say it's too early to say, and that's a perfectly good answer. Certainly in older people, depression and dementia can be very difficult to parcel out. Depression can be a prodrome of dementia. So that's your end point. You're trying to get to the point of giving an opinion, even if it's a wrong opinion. But do your testing intelligently. Anyway, I'm going to shut up for a minute. Simon, where are we at with questions? We're probably running out of time.
Yeah, I think we've got about a minute to go. There was just one question about where the recording can be accessed after the seminar, and I gather that it's going to be uploaded onto the web page, and people who, if you've registered for the session, you'll be able to access that hopefully reasonably soon. We've just got to iron out a few tech issues for that. There weren't any other questions, so I don't know if you want to make any closing remarks, Catherine, before we finish.
Well, only to say I hope it was helpful. Because I'm planning with Simon and Lane and perhaps another signer to do 3 more of these, it would be incredibly helpful to have a little bit of feedback if it was useful. And then so on the opening slide, I put my email address, catherine.n.carpenter@gmail.com. Do feel free to email me with any follow-up questions. So thanks very much for your time.